Okay. Hopefully this is where. You getting good sound back there? Okay. Okay, we're going to start our EMS trauma grand rounds today. And today we're going to speak on musculoskeletal trauma. And Ulna Zinger is going to speak to us. She has been here for about a year at our trauma service. She's a PA. And she worked before that at the North Shore University Hospital in Syosset, New York. Got her PA degree at Cornell University Medical College, and then also got a bachelor's degree at Pace University. And she's going to enlighten us on orthopedic trauma.
Thank you very much. Hello, everybody. Today, I'm going to talk about musculoskeletal trauma. Musculoskeletal injuries are among the most common problems you probably will see as an EMS provider. Appropriate care of musculoskeletal injuries immediately relieves pain and decreases the possibility of shock and further nerve or vessel injury. This care will also provide the patient's chances for rapid recovery and early return to normal activity. Just a brief introduction and reminder that about skeletal system. It consists of bones and associated connective tissue, including cartilages, tendons, and ligaments. The skeletal system provides a rigid framework for support and protection of our vital organs. It also provides a system of levers on which muscle act to produce body movements. The bones of the skeleton provide a framework to which the muscles and tendons are attached. Bone is a living tissue that contains nerves and receives oxygen and nutrients from the arterial system. That's why when a bone breaks, the patient typically experiences severe pain and bleeding. Injuries that result from application of traumatic forces include fractures, sprains, strains, and joint dislocations. Associated complications with fractures are hemorrhages, instability, compartment syndrome, loss of tissue, just simple lacerations and contamination, interruption of blood supply. You can also see nerve damage and long-term disability. I would like to point your attention and explore the compartment syndrome. Compartment syndrome usually develops over time as edema around an injured area increases, so it might not be seen at the initial stages of injury. It is commonly associated with fractures, arterial and venous bleeding from penetrating or blunt trauma, crushed injuries, and high-energy trauma. As a signs and symptoms of compartment syndrome, you will see severe pain or burning sensation. Patient will complain of decreased strength in the extremity. Also, you might see paralysis of the extremity, pain with movement, extremity feeling hard to palpation, distal pulses, and motor and sensory function possibly normal. Emergency medical care should focus on treating any life-threatening injuries first. You have to immobilize and splint the affected extremity, elevate the extremity, and apply a cold pack or ice, and transport the patient since he may lose the limb if the compartment syndrome is not treated quickly and effectively. So, musculoskeletal injuries can be result from direct, indirect, and twisting force. As you approach a patient with an injured extremity, you can get a good idea of how much damage may have occurred by determining the mechanism of injury. The injury from direct force occurs at the point of the impact. For example, a man in an automobile accident who is not wearing a seatbelt is thrust forward. The knee is hitting the dashboard. As a result, the patella may be fractured. With the indirect force, the force impacts on one end of a limb, causing injury some distance away from the point of impact. For instance, a woman is thrown from a horse and lands on two outstretched hands. One arm sustains a fractured wrist, while the clavicle, or as we call it, the collarbone often, at the end of the other arm is fractured. In twisting force, one part of the extremity remains stationary while the rest twists. Take the case of a child running across a field who steps into a hole. The child's foot is rammed snugly into the hole and stays stationary while his leg twists, fracturing the tibia and or fibula. Bone and joint injuries from twisting force occurs commonly in football or skiing accidents. So, what is a fracture? Fracture is a break in continuity of a bone. It may be complete or incomplete, depending on the line of a fracture through the bone. It also might be classified as an open or closed, and all depends whether the skin has been, if the skin's integrity has been compromised. So, fractures can also be classified as comminuted, oblique, transverse, pathological, epiphyseal, spiral, green stick. So here's the example of these fractures. So incomplete or green stick. So as you can see, the green stick fracture is when the fracture lines does not split the bone completely in half, and it's very common in children. Complete fracture is when the bone is completely transected. Comminuted, when the fracture site has a multiple little pieces of bone. Transverse fracture, when a bone is completely transversed and completely broken. Impacted fracture, where the bone ends are jammed together. Spiral fracture. Fracture line is a spiral or S shape, usually caused by a twisting force. So if you remember that example with the little boy running over the field. Oblique fracture is the bone is split diagonally, as you can see. So what are the common signs and symptoms of the extremity trauma? So you might see deformity, point tenderness, bruising, pain, swelling, crepitus, locked joint, guarding, false motion, exposed fragments, and decreased or absent sensory perception or circulation distal to the injury. So, musculoskeletal assessment. Patients who suffer musculoskeletal injury can be divided in 4 classes of patients. First is the patients with life, limb-threatening injuries or conditions including life, limb-threatening musculoskeletal trauma. The second group of patients is with the other limb-threatening injuries and only simple musculoskeletal trauma. The third group of patients are basically consist of with no other life, limb-threatening injuries and life, limb-threatening musculoskeletal trauma. And the last group of patients will suffer only isolated, not life, limb-threatening injuries. So what you have to do when you're assessing the patients? First, you conduct the initial assessment to determine if there are any life-threatening conditions, and you care for those conditions first. Never overlook musculoskeletal trauma, and never allow a non-critical musculoskeletal injury to distract from priorities of care. So what are the 6 P's of musculoskeletal assessment? First of all, it's a pain. Pain and palpation with movement or without movement. Pallor. pallor or pale color to the skin, distal to the injury site, and delayed capillary refill. Also, patient might experience paresthesia, a numbness or a tingling sensation indicating nerve damage. When you're examining pulse, distal to the injury that are absent or have a decrease in amplitude indicating damage to the arterial vessel. Patient may have paralysis and inability to move the extremity from nerve, muscle, tendon, or ligament damage. And last but not least is a pressure, which is a sensation in extremity associated with swelling. There are many important blood vessels and nerves lie close to the bone, especially around the major joints. Therefore, any injury or deformity of the bone may have associated vessel or nerve injury. For this, you must assess neurovascular function during the detailed physical exam and repeating it every 5 to 10 minutes, depending on the patient's condition. Always recheck the neurovascular function before and after you splint or otherwise manipulate the placement of a limb. Failure to restore circulation in this situation can lead to death of a limb, vessel, or nerve damage. So, while you are examining patient, you have to look for pulse. Palpate the pulse distal to the point of injury. Palpate the radial pulse in the upper extremity and the posterior tibial pulse and the dorsalis pedis pulse in the lower extremity. When you're examining for motor function, evaluate muscular activity when the injury is proximal to the patient's hand or foot. Ask the patient to open and close a fist for an upper extremity injury and to wiggle their toes and move the foot up and down for a lower extremity injury. Sensation is the ability of the patient to sense light touch in the fingers or toes, distal to the site of the fracture, and it's a good indication that the nerve supply is intact. In the hand, check the feeling on the palp of the index finger and thumb, as well as the little finger in the foot. Check the feeling on the palp of the big toe and on the dorsum of the foot laterally. Also, you would want to inspect and palpate injured area for deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, laceration, and swelling. When you're examining extremities, very important to compare the injured extremity with the opposite, uninjured extremity. If extremity trauma is suspected, immobilize the injury by splinting. So what are the general principles of splinting? The goal is immobilization of the injured body part. By splinting, first of all, it helps alleviate the pain. It decreases tissue injury, bleeding, and contamination in an open wound. It simplifies and facilitates patient transport. You would want to splint joints above and below and bone ends. Immobilize open and closed fractures in the same manner. You would want to cover open fractures to reduce contamination and further infection. Check pulses, sensation, and motor function before and after splinting. You want to stabilize the extremity with gentle inline traction to a position of normal alignment, and long bones extremity in a straight position that can easily be splinted. Dislocation, you want to immobilize in a position of comfort and ensure good vascular supply. Immobilize joints as found. Joint injuries are only aligned if there is no distal pulse. You would want to apply ice to reduce swelling and pain, apply compression to reduce swelling, and elevate the extremity if possible. Perform the reassessment, including recheck of the patient vital signs and interventions. Assess whether or not the injured extremity is properly immobilized. Make sure that the patient's distal pulses, motor function, and sensation have improved or have not deteriorated as a result of immobilization. So what are the types of splint mostly used? First of all, it's a rigid splint. It's designed in specific shapes for arms and legs and equipped with Velcro closures. These splints provide a firm surface in which to secure the bone to, so as to keep it in a straight alignment. Examples are Frax packs and B-splints. Soft or formable. These are malleable enough to form to a deformed or angulated extremity. These will form around the curved or flexed joints, still providing a firm support surface. Examples are ladder splints and SEM splints. And also traction splints. They provide a counterpull, alleviating pain, reducing blood loss, and minimizing further injury. This is the example of the rigid splint. Cannot be changed in shape and require that the bony part be positioned to fit the splint's design. Board splits, some cardboard splints, and you want to pad before use them. Soft or formable splints can be molded into various shapes to accommodate the injured body part. You can use pillows, blankets, sling, and swats. These are the examples of formable splints. Also, you can use vacuum splints, some cardboard splints, wire ladder splints, padded flexible aluminum splints, inflatable splints. There's quite a few to choose from, and you cannot use them for injuries proximal to the knee or elbow. Traction splints, they specifically designed for mid-shaft femur fracture. Do not apply or maintain sufficient traction to reduce a femoral fracture, but you do want to provide enough traction to stabilize and align it. Now I would like to go over some injuries. First is the shoulder one. Shoulder injuries are common in older adults because of the weaker bone structures, but they can frequently result from a fall on an outstretched arm. This is an example of dislocation of AcromioclavicularJoint. One of the shoulder injuries is anterior fracture dislocation. Patient often positioned with the affected arm or shoulder close to the chest. Lateral aspect of the shoulder appears flat instead of rounded. Deep depression between the head of the humerus and the acromion laterally. We call it hollow shoulder. So this is the example of the hollow shoulder. Posterior fracture dislocation. In this situation, patient may be positioned with the arm above the head. So how do you manage shoulder injury? First and foremost, you want to assess of the neurovascular status. And you will hear me repeating that with mostly all the injuries that I will be going over. Then you would want to do the application of the sling and swat. Don't forget application of the ice, and splinting may be need to be improvised to hold the injury in place. Humerus injury. These injuries are common on older adults and children. These are often difficult to stabilize. There are few associated complications that I would like to point to. One of them is a radial nerve damage may be present if a fracture occurs in the middle or distal portion of the humeral shaft. Fracture of the humeral neck may cause axillary nerve damage, and internal hemorrhage into the joint may occur as well. Management of humeral injury is, again, first of all, is an assessment of the neurovascular status. You would want to put a traction if there is a vascular compromise. Application of the rigid splint and sling and swat or splinting the extremity with the arm extended. and of course the application of the ice that will reduce the swelling. Elbow injury. These are common in children and athletes, especially dangerous in children. May lead to ischemic contracture with a serious deformity of the forearm and a claw-like hand. Usually involves falling on an outstretched arm or flexed elbow. Complications that you might see with elbow injuries are laceration of the brachial artery or radial nerve damage. This is the example of posterior dislocation of the elbow. You can see joint with marked deformity. Management of the elbow injury starts, again, neurovascular status. Splinting in the position found with a pillow, rigid splint or sling and swath. And ice. Radius, ulna or wrist injuries. Usually results from a fall on an outstretched arm. Wrist injuries may involve the distal radius, ulna, or any of the 8 carpal bones of the hand. Common injury is a Colles fracture. Forearm injuries are common in both children and adults. Here's the example of severe open fracture. You see the integrity of the skin is compromised, and you can see the bones going through the skin. Here's the example of penetration of the forearm caused by a nail gun. Again, you see the skin is compromised. Green stick fracture that we talked about earlier. These are very common in children, and this is how you would see it on the scene. Here is the fracture of the distal radius. So management of the radius, ulna, or wrist injury starts with a neurovascular status exam. Splinting in the position found with a rigid or formable splint or sling and swath, and application of the ice and elevation of the extremity. Hand injury frequently results from contact sports, violence, crushing in industrial context. One of the most common injury of the hand is a boxer's fracture. Results from direct trauma to a closed fist, fracturing the fifth metacarpal bone. These injuries may be associated with the hematomas and open wounds. As you can see, this patient's right hand is much more swollen than the left. This is the example of the hand injury involved in a motorcycle crash. So again, management of the hand injury starts with the neurovascular status. You would want to splint with rigid or formable splint in a position of function. Application of ice and elevation of the extremity will minimize the swelling. Finger injury. Finger injury may be immobilized with the foam-filled aluminum splints or tongue depressors, or by taping injured finger to adjacent one, as we call it body splinting. Finger injuries common, very common, and should not be considered trivial. Serious injury include thumb metacarpal fractures, any open fractures, and markedly comminuted metacarpal or proximal phalanx fractures. Management of the finger starts with a neurovascular exam. You want to splint it in a way I just described and apply ice and elevate the hand. Lower extremity injuries compare with the upper extremities. They are associated with a greater wound forces and more significant blood loss than the upper extremity injury may sustain. More difficult to manage in the patient with multiple injuries. They may be life-threatening One of the examples is a femur fracture. In the case of hip injury, they commonly occurs in older adults because of the fall. It may occur in the younger patients from a major trauma. If the hip is fractured at the femoral head and neck, the affected leg is usually shortened and externally rotated. Dislocations of the hip are usually evidenced by a shortened and rotated leg. Management of the hip injury starts as any other injury we just talked about, neurovascular status. Splinting with a long spine board and generously padding patient for comfort during transport. Slight flexion of the knee or padding beneath the knee may improve comfort. You do want to monitor frequently the vital signs. Femur injury usually results from major trauma, either motor vehicle crash or pedestrian accident, and they're a fairly common result of a child abuse. Fractures are usually evident from the powerful thigh muscle producing overriding of the bone fragment. Patients generally has a shortened leg that is externally rotated and mid-thigh swelling from hemorrhage. Bleeding may be life-threatening. Believe it or not, but thigh can accommodate as much as 2 to 3 layers of blood. Management of femur injury starts with not only neurovascular examination, but you would want to give high concentration of oxygen to the patient. If needed, patient needs to be treated for shock. Application of traction splint needs to be done, and it's for mid-shaft fracture. Regular monitoring of the vital signs is vital. So I would like you to see a video on how to apply a hair splint.
This station is designed to test your ability to properly immobilize. This station is designed to test your ability to properly immobilize. You will have an EMT assistant injury with the application of the device. You will have an EMT manual traction you in the application.
Sorry about that.
This station is designed to test your ability to properly immobilize a mid-shaft femur injury with a traction splint. You will have an EMT assistant to help you in the application of the device by applying manual traction when you're directed to do so. You are required to treat only the specific isolated injury. The scene size-up and initial assessment have been accomplished on the victim, and during the focused assessment, a mid-shaft femur deformity was detected. Ongoing assessment of the patient's airway, breathing, and central circulation is not necessary. You may use any equipment available in this room. You have 10 minutes to complete this procedure. Do you have any questions?
No. All right, BSI, scene is safe?
Yes.
I'm going to come down and take manual stabilization of the fracture site above and below the fracture. I'm going to have my partner come down and apply the ankle hitch and then pull manual traction. She is going to pull traction until the legs are the same length or the patient feels relief. Okay? Good? Okay. Then I'm going to check SMCs. Pulses. Can you feel this? Can you move it? Good. Now I am going to measure the splint against the good leg. Tighten it down. We're going to come back over to the injured leg. And on the count of 3, we are going to lift the leg and place the device. 1, 2, 3. Lift, 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 lift. I'm going to place the device up against the patient's ischium. And on the count of 3, we're going to put it down. 1, 2, 3. I'm now going to secure the ischial strap. Pad the femoral artery. We're now going to apply mechanical traction, again until the legs are the same length or the patient feels relief. Doing okay? Yes. We're now going to secure the leg straps. These, one above the fracture site, one below. I'm now going to recheck my SMCs. Pulses, can you feel it? Can you move it? I'm now going to move the patient to a long spine board. I'm going to secure the splint to the board and secure the patient's torso to the long spine board.
So as you have might notice, before and after he applied the splint, he did neurovascular status. He checked for pulses and movement. You have to make sure that after application of the splint, patient condition did not worsen. Knee and patella injury. Fractures to the knee and fractures and dislocations of the patella commonly result from motor vehicle crashes, pedestrian accidents, contact sports, fall on a flexed knee. The relationship of the patella popliteal artery to the knee joint may lead to vascular injury, particularly with the posterior dislocations. Here's the example of the knee injury from a pedestrian automobile collision. Management of these injuries starts with a neurovascular status examination, splinting in the position found with a rigid or formable splint that effectively immobilizes the hip and ankle, application of ice and elevation to reduce further swelling. Tibia and fibula injury. These may result from direct or indirect trauma or twisting injury. If associated with a knee, popliteal vascular injury should be suspected. Management of these involved assessment of neurovascular status, splinting with a rigid or formable splint, application of ice and elevation. Here are some examples of tibia and fibula fractures. This is the open fracture to the lower leg. This is how you would immobilize lower extremity. So foot and ankle injuries may result from crash, fall from the height, or violent rotary force. Patient usually complains of point tenderness and is hesitant to bear weight on the extremity. This is a subtalar dislocation. Foot that was run over by the wheel of a railway coach. Management of foot and ankle injury also starts with neurovascular status. Application of a formable splint, such as pillow, blanket, or air splint. Application of ice and elevation of the lower extremity. Phalanx injury, often caused by a stabbing the toe on an immovable object. These are usually managed by body taping the toe to an adjacent toe for support and immobilization. Management of this is not different from any others. You would want to assess a neurovascular status body splinting, application of ice, and elevation of the extremity. I would like to go over the open fractures. Consider any soft tissue wound around a suspected fracture to be evidence of an open fracture. Fractures may be open in two ways: from within, as when a bone fragment pierces the skin, or from without. As an example is a gunshot wound. An open fracture may have also made contact with the skin some distance from the fracture site. Open fractures are considered a true surgical emergency because of potential for infection. And once you bring them to us, we will take them to operating room immediately. Limb-threatening injuries consist of knee dislocation, fracture or dislocation of the ankle, and subcondylar fracture of the elbow. These injuries require rapid transport to the for physician evaluation. As a rule, fractures and dislocated joints should be immobilized in the position of injury and the patient transported to the emergency department for realignment or reduction, as we call it. If transport is delayed or prolonged and circulation is impaired, an attempt to reposition a grossly deformed fracture or dislocation joint should be done. You have only one attempt to do it. The elbow should never be manipulated in the pre-hospital setting. Handling the injury carefully, apply gentle, firm traction in the direction of the long axis of the extremity, and if there is obvious resistance to alignment, splint the extremity without repositioning. As I said, only one attempt at realignment should be made in the pre-hospital setting. Only if there is a severe neurovascular compromise, such as extremity is weak or absent distal pulses, manipulation, if indicated, should be performed as soon as possible after the injury. Should be avoided in the presence of other severe injuries. If not contraindicated by other injuries, consider use of analgesics for the realignment procedure. Assess and document pulse, sensation, and motor function before and after manipulating any injured extremity or joint. When realigning finger, apply inline traction along the shaft of the finger. Continue with a slow and steady traction until the finger is realigned and the patient feels relief from the pain. Immobilize the finger with a splint device or by body splinting. If you are realigning shoulder, attempt only in the absence of severe back injury. Check circulatory and sensory status. Apply slow, gentle longitudinal traction with counter traction exerted on the axilla. Slowly and without force, bring the extremity to the midline and realign it in an anatomical position while maintaining traction. You would want to, after that, immobilize with sling and swath for transport. Hip realignment. When you do that, you would want to apply inline traction along the shaft of the femur with the hip and ankle flexed at 90 degrees. Continue with slow and steady traction to relax the muscle spasm. You would know that you successfully done this procedure if you noted a pop into the joint, a sudden relief of pain, or easy manipulation of the leg to full extension. Immobilize the leg in full extension with patient positioned on long spine board. After doing that, reevaluate pulses and neurovascular status. Ankle realignment. Apply inline traction on the talus while stabilizing the tibia. Successful realignment will be noted by a sudden rotation to a normal position. Immobilize the ankle in the same manner as a fracture. Some patients with minor musculoskeletal injury, like example minor sprain, will not require EMS transport. To make this determination, Evaluate the need for immobilization. See if the patient needs an X-ray. Evaluate for need for a physician follow-up visit versus emergency department assessment. Patients who are not transported to the hospital should receive advice on how to care for their injuries. You might have a patient instruction sheet to give them out. If there is any doubt about the seriousness of the patient's injury, transport to the emergency department for physician evaluation. And in conclusion, I would like to stress that all extremity trauma is a seldom life-threatening. Early recognition and management may prevent long-term debilitating complications. Thank you very much.
I went in and out. I noticed that when you put ice on that, one of the things from the video that put something in the skin.
You're absolutely correct. First of all, you would like to prevent infection from bacteria to get into, especially if it's an open fracture. So you would want to, first of all, put some sterile dressing and then put ice on top of that. Absolutely, yes, you do have to. And if you apply ice, you would want to keep it on and off for about 10-15 minutes. Any other questions? Well, thank you once again, and good luck with your career.